Welcome to this very important virtual class where we are going to look at the female reproductive cycles. Perhaps you're aware that pregnancy is an obvious manifestation of the female reproductive functions. But other than pregnancy, we are also aware that perhaps the female reproductive system, the beginning of menstrual flow in a woman is termed menarche, but this flow does not continue throughout life. The monthly flow is not there throughout life of a woman, and we are talking about maybe into old age. The monthly flows end at a particular time. The time the monthly flows end is termed menopause. As a matter of concept, we define menopause as cessation of the menstrual flow for 1 year. And that happened at some years, maybe between 45 to 49 or 50 years there for most women. The time that menarche starts, or let me say the age at menarche, which means the time that the menstrual flow starts in a woman, varies. The age at which menstrual flow begins varies in a woman. This could depend on different populations, and perhaps there are more to do with the populations. Overall, we see that the time that menarche occurs could be dependent on the body weight of the female. And it's not just the overall body weight, perhaps dependent on the percentage of body fat compared with the lean tissue in the woman, as we're going to see shortly. So in this lecture, we want to first review the gross anatomy of the uterus and look at the histological layers of the uterine wall. After we've done that, we are going to explain the proposed mechanism that explain the initiation of female puberty. After that, we look at the hormonal axis that control the female reproductive cycles. Commonly, it's called the hypothalamo-hypophyseal ovarian axis. This is the hormonal axis that controls the female reproductive cycles and perhaps female reproductive functions. We'll then look at the cycle length, how long does it take each cycle, and explain how it varies. We'll also then look at, importantly, the changes which take place in the ovary every month. Let's call them the ovarian phases. And also look at the hormonal changes associated with each phase. We'll also look at the uterus, the inner layer of the uterus called endometrium. We look at the changes that occur in the inner layer of the uterus every month, and look at the hormonal changes associated with these endometrial changes. Perhaps you've heard about the concept of safe days. We'll also revisit that in this lecture. We look at the scientific basis of the safe days. Now, the idea of safe days is for a woman to be able to be aware of her fertility window so that perhaps she may avoid sex during that period or use other means so that she cannot get pregnant. For that reason, we call them fertility awareness-based method of contraception. But not all the time you want to know the fertility window because you want to avoid pregnancy. Sometimes you want to know the fertility window because you want to maximize on the chances of getting pregnant. So I want you to look at it in those two aspects and we'll discuss both. Lastly, we'll explain the basis of gender selection. You may have heard of people saying, I want a baby boy, so I'll do this to get a baby boy, or I want a baby girl, so I'll do this to get a baby girl. We're going to see the basis of this. Okay, so let's address the first agenda, which is just to look at the anatomy of the uterus. We look at the gross anatomy as well as the histological anatomy. So we know that the uterus is located in the pelvis. Grossly, it has the following parts. This upper part that extends up is called the fundus of the uterus. Then this middle region here, the bigger part, is called the body of the uterus. The lower end of the uterus is called the cervix. The junction between the body and the cervix around this part is known as the isthmus of the uterus. And then that part of the uterus where the fallopian tubes attach is called the conus of the uterus. It means a horn, so the uterine horn. So there are those 5 gross parts of the uterus: fundus, body, cervix, isthmus, and the conus of the uterus. Perhaps we can also learn the fallopian tube, as you can see it here. These are the uterine tubes. So uterine tubes also have parts, like this is the fimbria of the fallopian tube. This is the infundibulum of the fallopian tube. Sorry, yes, the infundibulum of the fallopian tube, which is the funnel part. Then this is the ampulla of the fallopian tube. And this region here is the isthmus of the fallopian tube. Remember, this one is also an isthmus of the uterus. Now this is isthmus of the fallopian tube. It's a narrow part. Then there's that part of the fallopian tube that traverses the uterine wall. We may call it the intramural segment of the fallopian tube. We see that the ovaries are on either side of the uterus, together with the ligaments that suspend or anchor or support the uterus somehow. The structures on either side of the uterus, the broad ligament, the ovary, and the fallopian tube together constitute generally what we call uterine adnexa. When you look at the sagittal section of the uterus, so this will be the fundus, this will be the body, and this is the cervix. And so this cavity within the uterus is called the endometrial cavity or uterine cavity. And the path through the cervix is called the cervical canal. With respect to the cervical canal, the lower opening of the cervical canal is called the external os, and the upper opening of the cervical canal is called the internal os. The lower part of the cervix is called ectocervix, and the upper part of the cervix is called the endocervix. This is the vagina, and the parts of the vagina that surround the cervix are known as the fornix. So this is the anterior fornix, and that's the posterior fornix. Now let's look at the histology of the uterus. Histologically, the uterus is described to have 3 layers. The outermost layer is known as the perimetrium. It's a thin layer of membrane and connective tissue that just cover the uterus, a thin one. Then the middle layer of the uterus is known as the myometrium. The myometrium refers to the layer of the uterus that contain uterine smooth muscle. So uterine smooth muscles are within the myometrial layer. Within this myometrial layer, there's some blood vessels. These are plain that contain large blood vessels. The plane of the myometrium that contain the blood vessels is otherwise termed the stratum vascularis. It means the vascular layer. And so this is the vascular layer of the myometrium. It is important that we have muscles within the myometrial layer so that when the myometrium contracts, as would occur after a baby has been born, then these blood vessels also shrink or vasoconstrict, so to speak, to prevent further blood loss after a baby has been born. So it's important that these blood vessels are actually within the myometrium, because the myometrium is the one that will contract to then occlude the vessels. The innermost layer of the uterus, this one here, is known as the endometrium. And the endometrium would consist of the endometrial lining, which will be an epithelial lining, some loose connective tissue within it, you may call it lamina propria, and glands, we call them uterine glands. Well, there are blood vessels which also extend into the endometrium. We divide the endometrium into two zones. The part of the endometrium basalis. This part of the endometrium is the one that remains when a woman menstruates. So this part is not shed off during menstruation. But there's this other part that is near to the lumen of the uterus, that's the stratum functionalis. This is the part of the uterus. This is the part of the endometrium that is shed off during menstruation. So stratum functionalis is shed off. Stratum basalis is not shed off during menstruation. Right. Now that we've talked about the general anatomy of the uterus, let's look at the proposed mechanism that explain the initiation of female puberty. We have already indicated that maybe adipose tissue has a role in the initiation of female puberty. Now, this is the concept. As a girl grows from childhood towards puberty, of course, they increase in size. And that means that the proportion of adipose tissue in the body also increases. That increase in the amount of fat is going to be very fundamental in explaining the initiation of puberty. But first, let's define puberty. What is puberty? It is a process through which a child's body matures into an adult that is capable of sexual reproduction. And so because we are talking about female puberty, so we can say it's a process through which a girl matures into an adult female that is capable of sexual reproduction, to mean capable of carrying pregnancy, conceiving and carrying pregnancy. That process is initiated by a chemical factor termed leptin. Leptin is a hormone that is produced by adipose tissue. That increasing amount of adipose tissue in the female increases. And so as leptin increases, because adipose tissue produces leptin, as the level of circulating leptin increases, this leptin will promote the secretion of another factor within the hypothalamus, which is termed kisspeptin. It may also be called metastine. Kisspeptin is produced by the hypothalamus. It is something within the hypothalamus. So leptin induces or promotes secretion of kisspeptin in the hypothalamus. Kisspeptin in turn promotes the secretion of a hormone termed gonadotropin releasing hormone. Gonadotropin releasing hormone is also produced by the hypothalamus. Now, central to the initiation of puberty is the beginning of production of gonadotropin releasing hormone. That is what is central in the initiation of puberty. Gonadotropin releasing hormone now start being produced in large amounts. And usually it's produced in a pulsatile format, which means that it's not continuous. The levels will be produced for a season, then goes down for a season, then also increase for a season. But when we begin to have that pulsatile increase in the secretion of gonadotropin releasing hormone, then we know that puberty is beginning. And this will continue throughout the female reproductive cycles. So exactly what does gonadotropin releasing hormone do? Gonadotropin releasing hormone, as the name suggests, promotes the secretion of gonadotropic hormones. There are two gonadotropic hormones which are produced by the pituitary gland. We have the follicle stimulating hormone and you have the luteinizing hormone. Both of them are produced by the anterior part of the pituitary gland, what is otherwise termed adenohypophysis. So when GnRH enhances the production of FSH and luteinizing hormone from the adenohypophysis, these gonadotropic hormones, as their name suggests, act on the female ovary in this case. That's the gonad we're talking about in this case. The effect of these hormones on the ovary would be to promote the secretion of estradiol, which is estrogen in simple terms. And so we'll have production of estrogen from the ovary. Now, I hope you're following that first, the hallmark was actually increase in pulsatile secretion of GnRH, which then influence the secretion of FSH and LH in a pulsatile manner as well because of the stimulant is pulsatile. And that this will then cause, again, some phasic production of estrogen. So when these hormones begin to be produced at that particular age, then we know that actually puberty has started. What will this do? The hormonal changes that we've described will in one way trigger ovulation, and we're going to see how ovulation is triggered. They'll also just trigger the beginning of the cycles, actually. And so this will mark the onset of puberty. And the onset of puberty in female is marked by the first menstrual flow, which we termed menarche. Well, nevertheless, when a woman begins the reproductive cycles, when menarche occurs, and so we know that reproductive maturity has been attained. In the earlier ages, in the earlier days of a female, the cycle lengths could be varying a lot. A cycle length, the duration between one flow and the next flow. Cycle length will vary a lot. Sometimes it could take after 10 days, there's another flow, and that may even be made a woman to panic actually. Sometimes it can even last for 2 months or even more. This is okay, it's physiological because the reproductive cycle has not fully matured and so it's still trying to establish some regularity. It's also important to mention that during that time, at that particular age, some cycles may actually not be associated with ovulation. There'll be anovulatory cycles, and that is still physiological. So this image tries to capture what I have summarized for you in the previous slide, that the hallmark would be the release of gonadotropin releasing hormone from the hypothalamus, which act on the pituitary to cause release of gonadotropic hormones. that will then act on, in this case, remember we're following the female one. And so it will act on the ovary to cause release of estrogen, which will then be responsible for the various changes that characterize female puberty. The age at which puberty begins may vary, maybe from around 8 years or 9 years there. That's when these changes begin to take place. Okay. Now let's talk about the components of the hormonal axis that control the female reproductive cycles. We've said it in a different way, but let's just put some clarity to it. We've mentioned that hypothalamus produces gonadotropin releasing hormone, which goes to the pituitary gland. The part of the pituitary gland that receives gonadotropin releasing hormone is the anterior pituitary gland, which we call adenohypophysis. In response to GnRH stimulation, the adenohypophysis produces gonadotropic hormones. There are two. We have follicle stimulating hormone and we have luteinizing hormone. Because they are gonadotropic, it means they are tropic to the gonad, which is the ovary in this case. So they act on the gonad, they stimulate the gonad. Among many things that these hormones do, I want you to remember some key things about each of them. Follicle stimulating hormone, as the name suggests, stimulate the ovary so that the ovarian follicles can continue to grow. So it fuels the growth of the ovarian follicles, which means that it stimulates folliculogenesis. This is basically oogenesis, maturation of the oocytes. Remember, they're found within follicles in the ovary. And as that happens, as the follicle matures, we note also that the levels of estrogen secretion will also increase. So by extension, either directly or indirectly, FSH also promotes the secretion of estrogen. Luteinizing hormone, on the other hand, is associated with ovulatory events. And so the rise in luteinizing hormone, and especially its surge, usually causes changes in the ovary that lead to extrusion of the oocyte. That's what we call ovulation. Around that time, the cells within the ovary also change their characteristic to produce more of progesterone hormone and perhaps less of estrogen hormone. And so we can also say with clarity that luteinizing hormone also promotes the secretion of progesterone hormone from the ovary. This is the hormonal axis in female, and these hormones, estrogen and progesterone, are the ones that now have influence in the uterus to cause the changes which occur in the uterus. So they affect the endometrial cycles. Well, they also affect the ovarian cycles in one way or another. Okay, so now let's talk about the normal cycle length. And we are going to also explain how it varies. I've defined the cycle length for you as the period between the beginning of one flow and the beginning of the next flow. So how long does that take? That's what we call cycle length. Don't confuse it with the duration it takes for the bleed to stop, which would be around 5 days plus minus 2, which means from around 3 days to 7 days. When the bleeding starts in a woman, it can last for 3 days, 4 days, 5, 6, 7. That's still considered normal. But that's not cycle length. Cycle length is the duration it takes from the beginning of one flow and the beginning of the next flow. So the cycling varies a lot. As an adolescent proceeds into adulthood, we agreed that there was no regularity at the beginning of puberty, but as the adolescent proceeds into adulthood, some regularity begin to be established. And this would range from around 21 to 45 days. We are not saying that that's actually the optimal, but at least the cycle is beginning to stabilize in a way. Now, for most adult female, which means they have now reached adulthood, an average of 28 days is actually optimal. Most women will have their cycle length between 27 to 30 days. However, for physiological reasons, a duration of 21 to 35 days is considered normal in adult female. So we can say it is 28 days plus minus 7, which means that a woman's cycle may take 21 days. So that means that if she started bleeding on, let's say, 1st of January, she may start bleeding again on 22nd of January, the same month. So it means that sometimes a woman can see a menstruation twice in a particular calendar month, and that's still okay. It also means that sometimes a woman may not see flow in a particular calendar month, and that is still okay. So don't associate the physiological month with the calendar month. They're not necessarily the same thing. As a woman grows towards old age, and they're approaching menopause for that matter, about 2 to 8 years before menopause, the cycle length begin to increase again. So they'll no longer be around 28 days, but perhaps longer. Some of them will take maybe 35, 40, 45. They begin to lengthen again until they finally disappear. And we agreed that when they disappear for 1 year, then we call that menopause. Important to note is that the cycle length can be altered by a number of factors, even if the female cycle is usually regular, that a woman has usually a regular cycle, and this is adult female we're talking about in this case. For example, if the woman is so much stressed emotionally, if she's sick, if she's malnourished, if she's obese, just some seasonal variations, it can make the cycle length to actually vary. So the cycle length is subject to a lot of variation, that's the point, and that is still physiological. So when sometimes someone has a regular cycle, then this particular month, though some delay or come early, it shouldn't be considered so abnormal, really. Understand that can also just be part of normal physiological variation based on some external factors. Okay, now I want us to explain the phases of the ovarian cycles, or rather the changes which occur in the ovary during a particular cycle. We'll also look at the hormonal changes that are associated with them. So at the beginning of each menstrual cycle, the pituitary releases follicle stimulating hormone. At the beginning of each cycle, the pituitary releases follicle stimulating hormone. Remember, this is in response to gonadotropin releasing hormone from the hypothalamus. Follicle stimulating hormone, we indicated that will have an effect on the ovary by promoting follicular development. For that reason, this first phase of the ovary is termed the follicular phase. So the follicular phase would be considered to begin on the first day of each cycle. This period is characterized by recruitment, growth, and development of ovarian follicles. Every month, about 15 to 20 follicles are actually recruited and stimulated. This stimulation is done by the follicle stimulating hormone. Now, because the follicle stimulating hormone causes the follicles to increase in size, and so the number of follicular cells and granulosa cells increase, it means that the amount of estrogen that is produced from the ovary also increases steadily or progressively, because we know that estrogen is produced by the follicle. So if the follicles have been stimulated to grow, remember, it's not just one, they're multiple, and they're all secreting estrogen. It means that the levels of estrogen will increase during the follicular phase. It is for this reason that we call the follicular phase of the ovary the estrogen phase, because during this period, the levels of estrogen increase. As the levels of estrogen increase, it causes a negative feedback on the pituitary gland. The rising levels of estrogen, especially in the early follicular phase, causes a negative feedback on the pituitary gland. And this means that it will suppress the secretion of FSH, if you understand the concept of negative feedback. So the rising levels of estrogen during the early follicular phase suppresses further production of follicle stimulating hormone. Now, something that you need to know about the follicles which have been recruited, we have agreed that about 15 to 20. They'll be growing at different rates. So some are large, some are small. The smaller follicles are FSH dependent, which means that they rely on FSH. The larger follicles are relatively FSH independent, which means that they don't necessarily need the FSH when they reach a particular size. So I want to link those concepts. When the levels of estrogen are rising, because there are many follicles growing, others small, others big, the levels of FSH go down as a result of negative feedback. Because the levels of FSH go down as a result of negative feedback, that will affect the smaller follicles in the ovary. So what will happen to them is that they'll not proceed. They will undergo atresia. The smaller follicles undergo atresia because of a decrease in the FSH levels during the follicular phase, and especially early follicular phase. However, the larger follicles, because they are FSH independent, will not be affected by the decrease in the levels of FSH. For that reason, they'll continue to grow. They'll become big. The largest of them all will be called the dominant follicle. Those are terminologies which are used in reproductive cycles, the dominant follicle. So the dominant follicle is the largest of the follicles. That does not mean that you only have one large follicle. You may have a few large follicles, but the largest is called the dominant follicle. You might call it the leading follicle as well, because it's the one leading in size. Great, so that is the follicular phase of the ovary. Follicular phase would last for about 13 days in most women. Let's consider that situation, therefore, one of the follicles has become big from the ovary. And so that leads us to the ovulatory phase of the ovary. Before I explain to you the process of ovulation, you need to understand that during the late follicular phase, we have rising levels of estrogen. Remember, the levels of estrogen have been rising because the sizes of the follicles have been increasing. The rising levels of estrogen causes a rise in the receptors of GnRH that will be in the pituitary gland. And that has an effect. Now, I want you to understand that very well. Estrogen usually increases the receptor density of GnRH in the pituitary gland. So because estrogen increases the receptor density of GnRH in the pituitary gland, it means that when you have high levels of estrogen, we can equate that to higher levels of GnRH receptors in the pituitary gland. And if you understand that, then we can also equate that to perhaps increased sensitivity of pituitary gland to GnRH, which means even small amounts of GnRH would then make the pituitary gland to respond massively. So how will pituitary gland respond to GnRH? By causing increase in FSH and LH levels. So do we see something? That in the late follicular phase, we are not talking about a negative feedback mechanism, but we are talking about a positive feedback mechanism. A rise in the levels of estrogen has actually led to tropic hormones. That's a positive feedback mechanism. Now, not a negative feedback mechanism that was present in the early follicular phase. So because of this increase in the levels of FSH and LH, and especially they're produced in form of a surge, because of that increased sensitivity, the surge in FSH and LH are very fundamental in causing the events, the molecular events that lead to ovulation. In particular, the luteinizing hormone surge will cause an increase in progesterone levels in the ovary. An increase in the progesterone levels trigger the molecular events that lead to follicular rupture. And if the follicles ruptures, then the oocyte will be expelled from the ovary, and that's what we are calling ovulation. So let's look at this flowchart. I may not explain in detail, but just somehow have an appreciation of what's happening. That a rise in the luteinizing hormone causes a rise in progesterone secretion from the ovary. A rise in progesterone secretion from the ovary causes some molecular changes in the ovary that will lead to follicular rupture and finally expulsion of the oocyte from the ovary. So those molecular changes, we may not go into them in particular, but they may include production of some enzymes as well as secretion of some chemical messengers called prostaglandins. That would lead to weakening of the wall of the ovary, as well as the wall of the follicle, and also will lead to the swelling of the follicle, which means that the follicular antrum increases massively. Eventually, the follicle will rupture and ovulation will take place. after ovulation, what happens? After ovulation, the next phase is the luteal phase of the ovary. One of the things that luteinizing hormone also do to the ovary is that it transforms the supporting cells of the follicles. Remember, they're granulosa cells. And external to the granulosa cells, you have the thicker internal cells. The surge in luteinizing hormone transform those cells to become what we call the corpus luteum, luteinization of the follicle. A follicle that has undergone luteinization changes its characteristics in terms of the predominant hormone that it will secrete. Usually, we prefer even changing the names of the cells. So the granulosa cells of the follicle, remember, these are the granulosa cells of the follicle. The granulosa cells of the follicle become the granulosa lutein cells. So they'll be here as granulosa lutein cells. And then the thicker follicular cells, especially the thicker internal cells, which will be somewhere around there, become the thicker lutein cells. The granulosa lutein and the thicker lutein cells eventually produces more progesterone than estrogen. Remember, initially in the follicular phase, they're actually producing a lot of estrogen. And as the follicle was increasing in size, the levels of estrogen also increasing. At this time, we switch the hormones so that it's more about progesterone being produced and less of estrogen. That doesn't mean that estrogen is not produced. It's just that progesterone levels are increased significantly. And because of this rise in the production of progesterone, this phase of the ovary is termed the progesterone phase. So that I want you to understand that in terms of hormonal events, we can just talk about two phases of the ovary. The first phase being the estrogen phase that will lead us to the events that will then initiate ovulation. Then the second phase is the progesterone phase. That is the things that occur after ovulation has taken place. So they're just those two hormonal phases, estrogen and progesterone phase. But in terms of the morphological events that take place within the ovary, I have described three phases: follicular phase, ovulatory phase, and the luteal phase. Now, corpus luteum, which is present during the luteal phase, does not last forever. Usually, it will only last for about 11 to 14 days if there's no pregnancy. But as long as corpus luteum is there, then we have a supply of progesterone hormone. Now, I want you to think through that well. It means that if the corpus luteum is not there, we will not have supply of progesterone hormone. And even the levels of estrogen will also go down. That is what is expected after 2 weeks from ovulation. 2 weeks from ovulation, we don't have a corpus luteum. The corpus luteum has involuted. That means, therefore, that 2 weeks after ovulation, the levels of ovarian hormone, that would explain why then something happens in the endometrium in response to depletion of the ovarian hormones. When we compare the progesterone phase, or we can say this way, when we compare the follicular phase and the luteal phase, we see that the luteal phase is relatively fixed at around 2 weeks. The follicular phase varies a lot. And so when we talk of a woman's length, cycle length being 35 days, it most probably means that this woman does not necessarily ovulate on the mid-cycle. For example, don't think that now perhaps they're ovulating on day 17, day 18. Well, let me put it this way. If a woman has a cycle length of 28 days, we would expect this woman to be ovulating on day 14. That's mid-cycle. But if a woman has a cycle length of, let's say, 24 days, this woman may not necessarily ovulate on day 12 that you're now taking mid-cycle. This woman is most probably ovulating on day 10. Why? Because we are saying that the estrogen phase is the one that is variable and that the progesterone phase is relatively fixed. And relatively fixed here means relatively fixed at around 14 days. So if I have a cycle length of 24 days, most likely I 10, so that 14 days later, the luteal phase is around 14. Then you work out the others, then figure out the possible day of ovulation. So I want you to capture that if a woman has a cycle length of, let's say, 32 days, they don't necessarily ovulate on day 16. Maybe she ovulates on day 18 of the cycle. So that you add 18 to 14, you get 32. I hope you've understood. So those are the ovarian phases. Now let's look at the endometrial phases. The changes in the endometrium are caused by the hormonal changes, and in particular, the changing levels of estrogen and progesterone. So it is estrogen and progesterone that will act on the endometrium to cause the changes. Remember, the changes in the ovary were primarily caused by the gonadotropic hormones, which means follicle stimulating hormone and luteinizing hormone largely. Well, I know that estrogen also has a role there. But the changes in the endometrium are caused primarily by estrogen and progesterone levels. So let's see. I want us to start at that time when menstruation has taken place. So what happens? When menstruation has taken place, which means that we've lost the stratum functionalis, the endometrium will begin to regenerate itself. And that period of regeneration is what we are calling the proliferative phase of the endometrium. This proliferative phase of the endometrium does not necessarily start, actually, it doesn't start on the first day of the cycle. The first day of the cycle is the day that menstruation begins. And so this proliferative phase is starting perhaps 5 days later after menstruation had started, which means at the end of menstruation. Day 1 of the cycle of a female is the day menstruation begins. So proliferative phase begins some days into the cycle. So what is causing this regeneration? Remember, in the ovary, we already have follicle stimulating hormone being produced around this time, day 1 of the cycle. And so the levels of the number of follicles are increasing, or rather ovarian follicles are being stimulated, so their sizes are increasing, they've been recruited. That means that the levels of estrogen is increasing from the ovary. It is the rising levels of estrogen that causes this particular phase of the endometrium to take place. Because of that, therefore, we can equate the proliferative phase of the endometrium to the follicular phase of the ovary. And that means we can equate it to the estrogen phase, therefore. So the proliferative phase of the endometrium is still the estrogen phase of the endometrium. It's caused by rising levels of estrogen. So this graph shows you the hormonal changes we talked about during the early follicular phase. We have rising levels of estrogen from the ovary. And as the levels of estrogen rise, we have an impact, therefore, in the endometrium. The endometrium responds to the rising levels of estrogen by endometrial proliferation. This endometrial proliferation would last as long as the levels of estrogen are also there. Around that time that the endometrium is proliferating by regenerating its inner layer that was shed off, the mucus of the cervix also has some changes. It becomes thin, and especially when the levels of estrogen, okay, so let's put it this way, that the levels of estrogen are rising. As the levels of estrogen rise, the cervical mucus usually is initially thin and watery. But as the levels of estrogen rise towards peak, the cervical mucus also changes its characteristic. First of all, it becomes a lot and becomes more elastic, which means it's more stretchy. I want you to link this with the event that's almost taking place, which is ovulation. So that at that time when the levels of estrogen are at peak, which means we have impending ovulation. That time when you have impending ovulation and actually go into ovulation, the cervical mucus is a lot, it's abundant, and also more elastic. This is one of the things that can be used to determine that a woman has actually ovulated. The abundance and elasticity of the cervical mucus. Okay, so that is with regard to the cervix, but generally remember that the proliferative phase is that period when the epithelium, the endometrium regenerates itself in response to estrogen, so we call the estrogen phase. Now, remember in the ovary, after the estrogen peak, we'll have something, the positive feedback into the pituitary, which causes a surge of luteinizing and follicle stimulating hormone. Therefore, they're going to have an effect in the ovary, which is going to lead to ovulation. And that when ovulation takes place, then we have a corpus luteum in the ovary that is now producing progesterone. And so the levels of progesterone begin to rise. It will have an effect on the endometrium. That will take us to what we call the secretory phase of the endometrium. The secretory phase of the endometrium is marked by branching and curling of the endometrial glands, as well as the blood vessels which extend into the functional layer of the endometrium. So those blood vessels. The glands of the endometrium secrete a thin glycogen-rich fluid. And because they produce this fluid, that's why we call this phase with menstrual phase. The secretion we're talking about here is just some thin glycogen-rich fluid, which is actually nutrient-rich fluid, actually. This is in preparation for implantation. We are now assuming that the egg that was being released would be fertilized. And so the endometrium is now being prepared for implantation, possibility of implantation. The changes I've told you that are occurring in the endometrium during this period is largely because of the rise in progesterone. And so the secretory phase of the endometrium is termed the progesterone phase of the endometrium. So in this graph, we see that after the peak of the estrogen levels, it will cause something in the pituitary that will cause a surge in the gonadotropic releasing hormone. Therefore, ovulation takes place. And after ovulation has taken place, we have a rise in the levels of progesterone. Even estrogen will still rise because of still being produced by the corpus luteum, but we see that now it's predominantly progesterone, and that's why the second phase, this particular phase, is termed the progesterone phase. At this time, the amount of cervical mucus reduces. And it doesn't just reduce, it also becomes thicker and more sticky. Now, think about that. If the mucus is thick and very sticky, gluish, it means that if sperms are deposited here, they may not go far. So it's a mechanism of blocking sperm transport along the female tract. During the secretory phase, we are assuming that fertilization has already occurred. And so we don't need the sperms anymore. Remember, in the previous phase that we call the proliferative phase, when the levels of estrogen were at peak, the cervical mucus became more abundant and even stretchy or more elastic. As a matter of fact, this kind of mucus is optimal for sperm movement. So which means that at around the time of ovulation, the changes in the cervical mucus are important to facilitate sperm transport. Now, this is a mechanism of just being ready to receive the sperm because the oocyte is also ready there. But after that window period, there's no possibility of conception. So even the sperms are now not needed. And that's why the morphology of the cervical mucus changes as well. Now remember that the corpus luteum, and remember that corpus luteum does not last forever. If pregnancy does not occur, it means that the corpus luteum will involute after 2 weeks from the time of ovulation. The impact of that is that the levels of progesterone and the levels of estrogen will go down. And so after 14 days from the time of ovulation, we can conclude that the levels of ovarian hormones are at their lowest. Remember, this secretory phase of the endometrium is only being sustained by the levels of the ovarian hormones which are there. So if the ovarian hormones go down, then of course the secretory phase cannot be sustained. And that's why then we have the menstrual phase. So the menstrual phase occurs following involution of the corpus luteum. Now that the corpus luteum from the ovary has involuted, the production of estrogen and progesterone has ceased. Therefore, we have hormonal deficiency. Because of this ovarian hormonal deficiency, the endometrium becomes ischemic. The blood vessels are just depleted, so there's less blood flow into the endometrium, and the endometrium basically disintegrates. This marks the beginning of the next cycle. It is menstrual flow. So it marks the beginning of the next cycle. Now, the menstrual flow usually lasts for 5 days plus minus 2. In terms of amount, it may vary. The discharge consists of blood, but the mucus, as well as just desquamated endometrial tissue, they're all in the menstrual flow. Routinely, menstrual flow does not really clot under normal circumstances. It just comes out because usually it has some anticoagulant within it that does not make it to clot. So it just flows. And I think that's a good thing. You could imagine if it was to clot inside, maybe it will have it difficult to flow out. All right, so remember that menstrual phase is the beginning of a new cycle. Around that time that menstruation is beginning, at the same time now in the pituitary, we have a fresh secretion of follicle stimulating hormone. And so we are beginning to then again recruit more ovarian follicles. It's a new cycle. Great, so I've explained this image in those slides which are coming before it, and I think we're okay here. So this shows you the hormones which are being produced from the pituitary, follicle stimulating as well as luteinizing hormone. And so in the ovary, they're responsible for the follicular phase and the luteal phase of the ovary. During the follicular phase, we have growth of the ovarian follicles that will lead to ovulation. You see when the ovarian follicles are increasing in size, in the early follicular phase, we have negative feedback. So we don't have high levels of FSH and LH, and look at that. FSH levels actually go down during the early phase because of the negative feedback. But as the levels of estrogen become high, and so the receptors in the pituitary are more, the pituitary become more sensitive to GnRH. And that means that then the levels of gonadotropic hormones increase in form of a surge. We have luteinizing hormone surge and follicle stimulating hormone surge, and this is what will lead to the molecular events that cause ovulation. After ovulation, the follicle that remains is called the corpus luteum. The parts of the follicle remain called the corpus luteum, which will last for the next 14 days. During that period, it will be producing ovarian hormones, predominantly progesterone. And that's why the second phase is called the progesterone phase. The first phase is known as the estrogen phase. So this estrogen and progesterone have effects on the endometrium. When the levels of estrogen are high, we have proliferation. When the levels of progesterone are high, we have the secretory phase. And when the levels of both hormones go down, we have disintegration. And so menstruation takes place, marking the beginning of the next cycle. All right, now let's explain the scientific basis of the safe days. I told you we can call it fertility awareness-based method of contraception. So a safe day, by definition, is a day that a woman is unlikely to conceive if she had unprotected sex. Which means that an unsafe day is a day that a woman is likely to conceive or has a chance of conceiving. There's a chance that she can conceive if she has unprotected sex. This awareness of the female cycle with fertility relies on a number of things. It relies on the cycle length of a woman. It relies also on the physical manifestation, the cervical ovulation like pain and the like. But it also relies on the duration it takes for the sperm and the oocyte to still be viable within the female cycle. You need to know that we are not just knowing the safe days for the sake of avoiding pregnancy. We are also knowing the safe days for the understanding that some couple may maximize on this period if they want to conceive. So anyway, now that it depends also on the duration that the gametes are viable, you need to ask yourself, what's the gamete lifespan? Now, sperms will last, or most of them will last for about 2 to 3 days within the female reproductive tract that's still viable. That may extend a bit to maybe 5 days sometimes, but majority of sperms will take 2 to 3 days in the female cycle, in the female reproductive tract. The oocyte is viable maximally within some hours after it has been released. Optimally, 24 hours, it may extend up to 48 hours in terms of oocyte viability. But optimally within 12 to 24 hours, that's optimal. So let's think through that and ask ourselves some things. Now, based on some studies which have been done, we've seen that if a woman has unprotected sex, 5 days to her ovulation, she has a 4% chance of conceiving. That tells us that there's some sperms which can live for 5 days, but 4% is a bit low. So maybe not many sperms will live up to 5 days. If a woman has sex 2 days to her ovulation, she has a 25 to 28% chance of conceiving. And this is actually the optimal one. We don't have 100% chance. It's not always guaranteed. So 2 days is actually the optimal, within 2 days to ovulation. That's the optimal period. If a woman has sex 24 hours after ovulation, there's an 8 to 10% chance of pregnancy. That tells us about the viability of the oocyte. That maybe the viability of the oocyte has decreased a bit, but could also be due to the changes in the cervical mucus that maybe prevent sperm transport at this time. So I want you to capture that the optimal time is within 2 days to ovulation. and maybe at the time of ovulation. Then after that, it decreases. The rest of the days of the cycle, there's zero chance of getting pregnant because the sperm and the oocyte may not meet, may never meet. Well, this graph tries to capture what I've just told you. So the optimal time of pregnancy is around maybe within 2 days to ovulation time. That's the optimal time. So we can use this to advise a woman who is trying to not get pregnant and she's not using other modes of contraception. If she has a 28-day cycle, then we know that she'll ovulate around day 14. That means that the days preceding ovulation, she has a chance of getting pregnant based on the viability of the sperm. And then 1 or 2 days after ovulation, again, she has a chance of getting pregnant based on the viability of the oocyte. So that's what we should use to calculate a safe day of a woman. And so think if it wasn't 28 days, it was 35. Remember what I told you, that ovulation perhaps would occur on day 20, 21 of that particular woman and not necessarily mid-cycle. So you need to understand that the day of ovulation is not necessarily mid-cycle, but you work it out based on what I told you in the previous slides. However, if a woman wants to conceive, then again, it means they can maximize sexual intercourse during this particular fertility window. So this is the fertility. She has a chance of getting pregnant. And this is the safe days within which if she has sex, she's unlikely to get pregnant. This needs to be customized to each woman after she knows her cycle length, after she knows the regularity of her cycle. All right, let's now finish with the basis of gender selection. Is it possible for a woman to decide that I want to conceive a baby girl or a baby boy? Yes, it's possible, but it's a chance. It is not a certainty. This chance is based on the viability of the X sperm and the Y sperm within the female reproductive tract. We've agreed that sperms can stay for, most sperms stay for about 2 to 3 days. And we've agreed that some sperms may even stay up to 5 days or slightly more. Truth of the matter is this: the X sperm, the one that will determine if the conceptors will be female, that X sperm can survive in the acidic environment for a longer period than the Y sperm. And so it's the type of sperm that will live longer. However, that sperm does not swim very fast. It swims slowly. The Y sperm swims faster, but doesn't survive much in the acidic environment of the female tract, so it will die early. So think through it. If a woman has sex, let's say 4 days to her ovulation, there'll be still sperms in the female tract that can meet with the oocyte, but most likely most of those sperms will be the X sperms. But if a woman has sex on the day of her ovulation, the sperms will run towards the site of the oocyte. Most of the sperms that in the front line will be most likely the Y sperms. So there are two things to consider. We may consider sperm viability and sperm motility. When we rely on sperm motility for fertilization, then most likely the Y sperm will have an upper hand. But if you're relying on the duration of sperm viability within the female tract, then the X sperm will have an upper hand. So we work with those two then to think around or increase the chances of a woman conceiving female or male child. Great. Thank you very much. So we'll stop there. I hope you've understood the female reproductive cycles. Thank you very much. The next topic would be the first week of embryonic development.